Hi everyone, my name is Pooja Agarwal. I'm a second year radiology resident at Baylor College of Medicine. Today, I'll be moderating the chat for any questions, which we can address at the end. I have the pleasure of introducing Dr. Luke Gilman. Dr. Gilman, actually, do you want to mute yourself for just a second? We can hear the Kahoot background music. I can still hear it. It might be on another screen or another profile. Perfect. Alrighty, so I have the pleasure of introducing Dr. Luke Gilman. Dr. Gilman is an assistant professor in the breast imaging section of the Department of Radiology at Baylor College of Medicine. He currently serves as Associate Program Director for the Diagnostic Radiology Residency Program and Director of Breast Imaging Education. Dr. Gilman's academic interests center on competency-based medical education with a focus on developing rigorous outcomes-driven training for future radiologists. His commitment to educational excellence is informed by personal experience as a spouse of a breast cancer survivor, which reinforces his dedication to preparing radiologists capable of delivering care at the highest standard, care he would entrust to his own family. I've had the pleasure of personally working with Dr. Gilman. He's an amazing faculty, so y'all are in for a real treat. Dr. Gilman, take it away.
All right, thank you so much, Pooja. I really appreciate it. I'm going to give everyone a minute. I don't know if people have the ability to log on to a computer at their site to go to www.kahoot.it to sign into the game. If you are unable to sign in, that's fine, and we will get started in a minute. So you can just sign into that location, or you can use the barcode on there. And if you cannot log in with the barcode, you can just do the game pin with 381217. And I'll give everyone about a minute or two to do that. If no one's able to log in, at least Pooja, if you could log in from your location, that would allow me to start
Yeah,
from your
sure.
side. I just have to have one participant. I just wanted to give you guys a brief introduction to myself. Thank you, Pooja, so much for introducing me. I personally got into breast imaging because my wife is a breast cancer survivor. I really did not know what I wanted to do in radiology until she went through her experience about 5 years before I entered residency. My wife had a palpable concern in one of her breasts, and she went in to see a radiologist who did a mammogram and ultrasound, and that the senior resident that was with the radiologist at the time did an amazing job with her workup as well as the biopsy. So it's my goal, and I just remember that experience. It's my goal to train radiologists and my radiology residents to be someone that I can entrust to take care of someone in my own family in the future. So I hope that this is a long-standing relationship that I have with Health for the World. Um, Today is really more of an introduction with introduction cases using a lot of the BIRADS terms that we use here in the United States. And I would love to have comments at the end, whether or not it's through the barcode that I have attached to the end or through responses to Health for the World, because I want to know how to tailor future lectures in terms of if y'all would want more mammogram and ultrasound, or if you want MRI. I acknowledge that there are different levels of resources in different communities, so I just want to make sure I'm cognizant of that. But we will go ahead and get started, okay? And Pooja, if you don't mind monitoring, if there's any questions, I'm happy to answer them. You can stop me at any time.
Perfect. Sounds good.
Okay, so here we go. So once again, I'm Luke Gilman. This is our interesting breast cases. My disclosures: I'm an academic radiologist at Baylor College of Medicine in Houston, Texas, and I have no financial disclosures. So we'll start in quiz format. So a 27-year-old female presents with a palpable finding in the left breast. What should be the next step? Okay, sounds good. So, two answers for left breast ultrasound. That is the correct answer. Okay, so what we like to use a lot here in the United States is what's called the ACR appropriateness criteria, and that really helps tailor us to go in the correct direction of what study we should perform first, what study we should perform next. For patients that are less than 30 years of age, we usually start with a breast ultrasound. And that's for several reasons. We like to minimize the amount of ionizing radiation that we're giving to females. Number one, and number two, females that are young often have denser breasts, so where it's much more difficult for us to visualize something on mammogram. And starting with an ultrasound is usually the first step, and we may be able to add a mammogram afterwards. Okay, so then here's the next question. What is the margin of this mass? Awesome. So the question is, what is the margin of the mass? So if you go back and take a look at the mass, you will notice that not the entire part of the mass has a circumscribed margin, but the remainder of the mass has what's called an indistinct margin where it's fuzzy. For us to call a mass a circumscribed mass, we have to have 100% of the margin has to be visualized as circumscribed under ultrasound. This is 75% on mammogram. And this is really important because masses that are circumscribed, that are seen on mammogram, most likely are going to be something like a fibroadenoma or a benign mass. Now, when those margins start to become indistinct, we start to get worried about whether or not something is a cancer. So when I speak with my residents, I remind them that the margins, the word is camus. It's circumscribed, so 100% of the mass is circumscribed. And any of the rest of the four margins are something that is going to be determined to be suspicious, and that's going to require an ultrasound guided biopsy. Okay, so great. I'm happy to explain this one. So the correct answer actually is papillary carcinoma. So we're going to go back and take a look at this image. So let's go forward. See, show media. All right, so this mass. So if you take a look at the image right here, there's the nipple right here. So this is very close to the nipple. In this area that's extending from the nipple is actually a duct, and this mass is within a duct. So the most common cancer that presents within a duct is what's going to be called papillary carcinoma. The most common mass that's within a duct is actually a papilloma, but papillary carcinoma, for any mass that's seen within a duct, we're going to recommend doing a biopsy. This is even if you do not see any color flow within the mass, you're still going to undergo biopsy. The reason why is some of these masses have such low levels of blood flow that color flow imaging may not pick up the color flow. So any intraductal mass will undergo biopsy. So intraductal masses, the patient could present with a screening mammogram. We do not, and the patient doesn't have any symptoms. We may see a prominent duct on the mammogram, or we may see a new mass on the mammogram, and we take the patient to ultrasound. And then there's patients that are presenting for diagnostic studies that they're either having clear or bloody nipple discharge. These are the two types of nipple discharge that we consider concerning. We consider black nipple discharge, yellow nipple discharge, and white nipple discharge to not be concerning. But usually a unilateral clear or bloody nipple discharge is going to be something that's going to get a workup from us. Your differential diagnosis is going to be a papilloma. DCIS versus invasive ductal carcinoma is also fine. And then there also can be benign debris within a duct. And I just want to go over the other answers. So, invasive lobular carcinoma, you're going to most likely see an invasive lobular carcinoma present as an irregular mass on ultrasound, or on mammogram, you're going to see it as a focal asymmetry with distortion. Invasive lobular carcinoma is different from invasive ductal carcinoma in the fact that invasive lobular carcinoma usually does not form a mass, and the cells will line up in a line. Where invasive ductal carcinoma, those cells are going to clump together, and it's going to be more of a mammographic or sonographic mass. Mucinous carcinoma is one of those other carcinomas that we see, which can usually present as a high density mass on mammogram. On ultrasound, it is often isoechoic to the rest of the fat. For us, we use subcutaneous fat to determine the echogenicity. And the reason why it's often isoechoic is usually these mucinous carcinomas contain fluid, because mucin is fluid. And so often it can have a varied appearance on ultrasound. If you have MRIs at your facility, this is one of those MRI findings that is very T2 hyperintense. That is not a benign finding. If you have MRI at your facilities, most T2 hyperintense masses are going to be benign, but mucinous carcinoma is not one of those. Okay. Any questions? Continue.
Dr. Gilman, quick
Yeah.
thing. Do you mind telling everyone the web URL and code again? Because I don't think we have a lot of participants because they don't know what the code is.
Okay. Let me see if I have the code
Or
again.
or I can just say it. It's kahoot.it and the
Yeah.
code is 381217.
Okay. And I'll wait about 1 minute to see if people can add on.
Right.
Apologize for that. I wasn't sure if people were logged in together as a team within their classroom, or if people are logging in individually. So I'll give about 30 more seconds. I'm happy to answer any questions while we're waiting if anyone has any questions. Okay, so I'm going to continue on to the next. We talked about nipple discharge. Okay, so I want everyone to take a look at this image right here. The calipers are essentially measuring a mass, and I want you to take a look specifically at the characteristics of this mass on ultrasound. Okay, so good. So we'll show the media again for this. So BIRAD's ultrasound descriptors for the mass. So this mass is a mass that is showing both solid and cystic components. The descriptor that we use for a mass like this is a complex solid and cystic mass. It contains both solid and cystic components. There can be areas in other parts of radiology where you can use complex solid and cystic mass. However, if you use this terminology within the breast, you are saying that this patient will need a biopsy. And you guys are able to see the image, right, when I pull up the media to the front. I just want to ensure that y'all are able to see that. Is
Yes.
that correct? Okay, perfect. So this will be something that you will need to biopsy. Two things that this could commonly be if it is malignant is, one, this could be a invasive ductal carcinoma that is aggressive, that has necrosed, meaning part of the mass has essentially the blood flow has gone away from that. It's a necrotic invasive ductal carcinoma, and that's why you get a cystic space. The other thing that this could commonly be if it's malignant is a papillary carcinoma. So this could be a complex solid and cystic mass that you may or may not see the associated duct. So we would even accept if this came back as a papilloma and not papillary carcinoma, we would consider this concordant. We will likely still recommend a 6-month follow-up or excision, just given its appearance. Okay. Okay. So ultrasound specialist cases. So the other things that I wanted to bring up. So We talked about complex solid and cystic masses. It must contain cystic and solid components that requires a biopsy. A complicated cyst is the image that we see on the left. That is a cyst with internal debris. That is commonly what we do with these is for patients that are premenopausal, especially if they have similar ones in both breasts, is we do not follow these. Sometimes we do follow them if it's in a postmenopausal patient, or if we're unsure if the echoes within the cyst itself are a solid component or debris. We will consider biopsy sometime in patients that are postmenopausal. Clustered microcysts is the bottom right. Clustered microcysts contain no discrete solid component. This is considered to be a benign finding with similar management to a complicated cyst. The really important thing to note with the clustered microcysts is that there is no discrete solid component. And if you take a look at the image at the top, you can see that there's solid components and maybe areas that look like it's a clustered microcyst, but the one at the top actually has solid components. We will often let these go or follow them in premenopausal patients. If we're concerned that this may be the start of a process in a postmenopausal female, we may end up following this just to make sure it doesn't grow in size or demonstrate a solid component at a later date. Okay, so 27-year-old male presents with a palpable finding in the left breast. So the important thing is it's 27 and male. Okay, so great question. So, or great here. So, I think maybe some of the answers that we are getting here is possibly because there's certain facilities that may not have access to mammogram. But if you do have access to mammogram and you do have access to ultrasound, the important thing is actually to start with a bilateral mammogram for male patients that are greater than the age of 25. So 25-year-old and up for males, we start with a bilateral diagnostic mammogram. 30-year-old females and up, we start with a bilateral diagnostic mammogram. So if we start earlier, about 5 years earlier with males doing mammograms, the reason why is males often do not have as dense breasts as females do. And so if there is something that is present, we will be able to see it quicker with a male at a younger age than we do with females. Okay, I have you take a look at this image. And the little oval that's here represents the nipple. So, what is the most common etiology of a palpable complaint in males? Great. So everyone answered gynecomastia, which is great. So if I'm going to go back and take this is gynecomastia right here that's actually demonstrated here. Usually gynecomastia looks like a retroareolar flame-shaped density. There's three different types of gynecomastia, or one starts just behind the nipple, then it extends to the entire breast, and the other one is usually bilateral and is usually seen with patients that have exogenous estrogen. And it's the most gynecomastia is the most common palpable finding in patients that are males. When we start to worry for males with a palpable finding is the palpable finding is away from the nipple. So gynecomastia is usually the most common complaint. It's central location under the nipple. It's often unilateral and asymmetric. I just had a patient 2 days ago that definitely had a lot of gynecomastia on one side and just trace gynecomastia on the other side. It's possibly due to an imbalance between androgens and estrogen. There's many causes out there, hormones, systemic causes like liver or renal failure. Tumors can secrete estrogen as well. Medications and an idiopathic, we just don't have a reason for why a patient has gynecomastia. The patterns are early nodular, so that was the one that was seen on the image that I showed. Chronic dendritic is going to be the entire breast, usually asymmetric, and that diffuse glandular is going to be usually bilateral, and it's due to exogenous estrogen use. Breast cancer is much less common. Breast cancer counts for about 1% or less of all breast cancers. Excuse me, breast cancers in male account for 1% of all or less of all breast cancers in males. It's often a unilateral, regular hard mass that's eccentric from the areolar, but we usually still get that mammogram because we are able to see other associated findings, even if that breast cancer is behind the nipple, like skin retraction, nipple retraction, or just a very dense asymmetry or mass that's seen on mammogram. Breast cancer in males is usually associated more with BRCA2, whereas breast cancer in females is more often associated with BRCA1. All right, going to continue on. Okay, so I'm going to give everyone a minute or two to think. So there's two cases here, and it's a two-part case. So the part A of the case, so you're going to give me two answers. Part A of the case is a finding is seen in the central left breast or central right breast, excuse me, central right breast on CC. And then we get what's called a rolled medial, meaning we roll the breast a little to the medial, and the finding goes lateral. So the question for part A is, where is the finding? Is it in the superior breast or inferior breast? Part B, so this is a second patient. We have a finding that was originally seen on the MLO view in the inferior breast. When we get a lateral view, the finding ends up rising. So it becomes a little higher. So where is the finding in case A and case B? Okay, so great. So one person answered inframedial, and a second person answered superior and medial. So this is, I think, this is one of the harder things in all of breast imaging. I think this is something that I probably at one point struggled with when I was a resident, and it's often something that I like to teach my residents just to make sure they know it before they take their core examination. So, the general rules. So, part A. So, we have a CC finding that ends up going lateral when we roll the breast medial. So, what I teach my residents is if you roll the breast on the CC, if the finding moves in the same direction that you roll the breast, then it is in the superior breast. So, this finding we had rolled the breast medial, the finding goes lateral. So the finding is actually in the inferior breast. Okay. For part B, where's the finding lateral or medial? So we started off with a finding in the MLO view. When we got a lateral view, it rose. So the really important thing here is what we teach our residents is muffins rise and lead sinks. So this finding rose, and muffins start with M. So it's in the medial breast. So muffins rise, lead sinks. Okay. And this is also something that I have residents look at. I'm not going to get too in depth here, but it explains how the finding goes from the superior breast to the inferior breast, and from the central breast to the lateral or medial breast, depending on what views you're getting for additional views. Questions? Okay, so once again, breast imaging localization with CC and roll views, same direction of the roll view, then it's in the superior breast, opposite direction inferior breast. With MLO and lateral views, if it moves superior on the lateral view, the muffin has risen and the lesion is medial. If it moves inferior on the lateral view, then lead has fallen and the lesion is lateral. Okay, so this is the next finding. So on the MLO view and the right breast on the mammogram, there is a tubular-like asymmetry that is seen in the superior breast. We got an ultrasound, and this is the finding. Awesome. So one person said bloody nipple discharge. The second person said palpable cord. Um, I think bloody nipple charge discharge is a possibility if it's an intraductal mass. But what I am trying to show here is something called Mondor's disease. So it's what's called aseptic thrombophlebitis. It's a essentially a patient is presenting with a linear palpable cord that they're filling. It's usually a superficial venous thrombosis that a patient had either due to trauma, due to hypercoagulability. There's many causes out there. That venous thrombosis is then recanalized, causing some fibromuscular hyperplasia and thickening of that wall. And it can be associated with trauma, can be associated with previous biopsies, catheters, hypercoagulability. The treatment for this aseptic thrombophlebitis is supportive treatment or NSAID. So usually, most patients don't require any medications. This is something that we call a do not touch lesion, meaning don't biopsy this lesion. This is something that should resolve on its own. Questions? Okay. So next question. What is the distribution for these calcifications? Okay, so two people said group and one person said clustered. Okay. Oh, let me go back. Sorry, I went too far. All right, so clustered was actually an old description that we used in the breast. The words now that we use is grouped. This is an image here that says in groups. So distribution. So the distribution. Why we use distribution in calcifications is it helps us determine what is the level of suspicion that we're seeing for a group of calcifications. I often teach my residents that the ductal system is often like a tree branch that with smaller branches that are branching out. And so, if we see calcifications that are in a segmental or linear area, that means multiple small tree branches are involved, and that's more likely to be suspicious. Grouped calcifications is an area that is 2 centimeters or less, and a regional calcifications is considered to be more than 2 centimeters. Diffuse calcifications are usually the least suspicious of all the grouped calcifications out there, um, and those are the essentially the least ones that likely to be cancer unless they are new on a patient that hey, you have previous prior mammograms. The morphologies include amorphous. So amorphous is appearance of they're kind of smudgy. Coarse heterogeneous is different size. Fine pleomorphic is what we consider to be what's called when you're smashing glass on the ground and you have shards of glass. That's usually the words we use. And then fine linear is you can see on your magnification views that they look like they're branching in small fine linear areas. Okay. So baseline screening mammogram, what is the BIRAD? So what I am showing you here is this oval mass that's in two views. Okay, great. So we have people all across the boards. So we have one person that answered BIRADS 3, um, one person that answered BIRADS 0, and one person that answered BIRADS 2. Okay, that's great. So baseline screening mammogram. So when we start off with a baseline screening mammogram, the mammogram itself at baseline has to be either a BIRADS 0 or a BIRADS 1 slash BIRADS 2. So it cannot be a BIRADS 3 or BIRADS 4 from a baseline mammogram. Okay. So I'm going to go back here. This is actually the correct answer is BIRADS 2. The reason why is this oval circumscribed mass contains fat. Um, any mass that's in the breast that contains fat, especially an oval circumscribed one that contains both fat and parenchymal components, is going to be something called a hamartoma. Okay. So a hamartoma, the other name for it is a fibroadenolipoma. It's the words are breast within a breast, so it looks like the appearance that there's a mass within the breast. The fibroadenolipoma actually has a pseudocapsule. There's no real capsule to the area. It's isocoic to the surrounding tissue on ultrasound, and if you have MRI, the MRI signal is essentially the same as surrounding breast tissue, and it's a BIRADS 2. Okay, so we're going to go over some breast MRI cases now. I want to tailor future lectures or future sessions that we have. And so when you do respond on what worked well and what didn't work well, if you'd like to for me to continue in the future show breast MRI cases, I'm happy to. But if that is not of high utility, then I will focus in the future doing more mammogram and ultrasound cases. Okay. So breast MRI is typically recommended for patients with high risk greater than what? So high risk patients are considered to be at risk greater than what percentage? Okay. So one person answered 20, another person answered 20, 25. So the correct answer is 20%, and I'll go over that after we do this one. Okay. So we are all over the place on this one, which is good because this will be a good teaching moment. So what is not an indication for breast MRI? So it's the only one that's not indicated for breast MRI is actually evaluation of saline implants. Okay. So let's talk. First indication for breast MRI. So it's first is the evaluation of a high risk patient. That's patients that are greater than 20% chance of having a breast cancer. Usually for us, if you were able to run a high risk panel, or you're able to use something like Tyrer-Cruzik to determine the overall risk. For us, we start thinking about, is this patient high risk if they have a family member that is a first degree relative, or more than one family member that's first degree relative with a premenopausal breast cancer. That's going to often increase your risk. But there are a lot of different factors out there that are used in the different models that out there. Evaluation of patient with clear or bloody spontaneous nipple discharge. That is something else that we use, especially if the mammogram and the ultrasound does not turn up anything. We'll lean towards doing breast MRI. If a patient has gone to surgery and the pathology comes back with positive margins, we can often take a patient to get a breast MRI after that. One of the main ones that we do at our institution is evaluation of extent of disease for no malignancy, especially in those patients that are premenopausal, that are dense, that have an invasive lobular carcinoma. We really want to try to do an extent of disease MRI for no malignancy. And often we can get evaluation of response to treatment after neoadjuvant therapy. We try to get that as much as possible at one of our locations. There is definitely a longer wait for MRI, so this is often not done, but it's something that we can do. And then with without contrast, indication for breast MRI is evaluation of silicone implants. So when a silicone implant is placed or a saline implant is placed, there's a capsule that forms around that implant. That patient can have a silicone implant rupture within that capsule that we cannot see on mammogram. The ones that we may be able to see on mammogram are extra silicone capsule rupture, but those intracapsular silicone ruptures we can't see. So breast MRI is used. The saline implants, the study that we do is actually physical exam. So if a patient has a saline implant rupture, we usually know immediately because that implant will deflate. Okay, so evaluation for intercapsular silicone rupture. So this is a patient that has this is the capsule that is formed around the implant. This patient has this is the actual implant right here. Their silicone is only supposed to be with inside the implant, not outside the implant. So there's actually silicone outside the implant, but within the capsule. This is what's called a subcapsular sign. This is a sign of a silicone implant rupture. This is also a subcapsular sign. This right here is once again, this is what's another sign right here, right, which essentially the what I call the candle in the wind sign. It's not really the sign, but I call it the candle in the wind sign because it looks like the implant line is right here. It's like floating like a candle in the wind. There's also another sign that we have teardrop right here. So there should only be silicone on the inside of the implant, where here it is on the outside. And then you can also see a little bit of silicone right here in between two folds. That is the teardrop sign. This is different from what something called a radial fold. That radial fold is where the two sides of the implant are coming together. There should be no silicone between the two. That would not be a rupture. Okay. Okay. Next question. So diagnosis. Okay, so the correct answer is invasive mucinous carcinoma. So one person answered fibroadenoma. That is another mass within MRI that can be T2 hyperintense. Let's see, somebody else put postoperative hematoma. The postoperative hematoma is more likely to be an oval area that may have some nice reticulations within it. So let's look at the media. So the two different sequences that I've shown here. The sequence that is on the left of your screen is actually a T2 sequence. So this is a T2 hyper intense mass. And this is actually the post contrast over here. So, like I mentioned earlier, and this kind of a fall from our one of our cases from earlier, or one of our descriptions from earlier. These are one of the masses that is a T2 mass that contains fluid that is not something benign. So this is a invasive mucinous carcinoma. Usually these cancers do not contain very much of a solid component, and so they often be irregular on MRI with a T2 hyper intense component, and often do not show much enhancement on your post contrast images. Okay, so invasive mucinous carcinoma, we talked about this. You need to ask yourself when you're looking at your images why certain sequences are shown. All lesions that you biopsy under ultrasound with mucin should proceed to excision slash lumpectomy if your facility is able, has the resources to do it. Invasive mucinous carcinoma is hyperdense on mammogram, often isoechoic on ultrasound, as we described earlier, and it's T2 hyperintense, irregular with varying levels of enhancement on your MRI. Okay, so this is a second MRI case. So this is the diagnosis and pattern of enhancement. Everything okay from y'all's end? Okay, sounds good. So diagnosis, most common pattern of enhancement. The correct answer is fibroadenoma with a persistent pattern of enhancement. The other answers are papillary carcinomas with washout. Okay, so what I'm showing here is a mass that on the pre-contrast is essentially isointense to the rest of the mass. And then when you look at the post-contrast images, there are things called dark internal septations within the mass. These dark internal septations are consistent with a degenerating fibroadenoma. This is considered to be a BI-RADS2 lesion or BI-RADS2 mass on MRI. Often, if we are not 100% sure, what we'll do is we'll take the patient back to ultrasound to confirm it's a fibroadenoma. Okay. So the next question is, what's so fibroadenoma is T2 hyperintense, persistent enhancement, oval circumscribed with dark internal septations. So excuse me, I went too fast. Apologize. Let me go back. Okay, so we'll answer this question, then we're going to talk about kinetics. Pixel percentage difference between persistent and plateau kinetics. Okay, so the correct answer is 10. I know this question came back quickly. Okay, so when we are looking at MRI, so we will get what's called a pre-contrast image, and then we'll get post-contrast phases. The program that is often sent with MRI will allow you to calculate something called kinetics. And essentially, kinetics is the pattern of blood flow within the breast. So what it's going to do is it's going to measure the amount of pixels in that mass on the pre-contrast. It will measure the amount of pixels in the immediate post-contrast phase, taken at a certain point, which is determined by your specific protocol. And it will take the amount of pixels at the late part. So when we think about breast cancers, we think of breast cancers are usually developed very quickly, meaning things that develop very quickly are going to be very angiogenic, which means that they should have a rapid uptake of blood flow into the cancer. So they will show what's called a fast, which is the dotted line, a fast initial part of the blood flow. But as many people know, when things are built quickly, they're not often built well. So those the blood vessels that are built by the cancer are going to be very leaky, which means that the most commonly that the kinetics for a lot of these cancers are going to show a rapid uptake, but it's going to do something called washout, meaning the blood flow is going to go into the cancer very quickly, and then it's going to go out of the cancer very quickly. And that's what's called the washout type pattern. Masses that usually grow slower are going to be a much slower initial, and then will continue to have blood flow that increase, which is considered a persistent pattern. Now, it's very important to acknowledge that kinetics is the least accurate thing to tell if something is a breast cancer or not. In terms of the number of percentage for the pixels between the immediate post and delayed post is 10%. So if something has 10% more pixels at the delayed time versus the immediate time, we consider that persistent. Whereas if it's lost more than 10% of the pixels between the immediate and the delayed, we're going to consider that to be washout. How are we doing with time?
It's 9:45. I don't know if you want to leave some time for questions. I've been
Yeah.
looking at the chat and no one has any questions so far.
Okay, sounds good. So I'll do one, maybe two more cases, and then we'll stop.
Okay.
Okay, so sounds great. It looks like one person had the chance to answered multicentric DCIS. The correct answer is what's called invasive lobular carcinoma. So I wanted to show you this. This is the classic appearance of the shrunken breast in an invasive lobular carcinoma. So if on here on the left breast, you'll notice that the breast looks normal. The breast looks It's of normal size, whereas the right breast that has it's involved with all this what's called enhancement here or cancer is smaller than the left breast. Now, on physical examination, the breast is not smaller on physical examination. It's actually that it's less. The ILC results in the breast being less compressible, so we're able to compress the breast less, and because we're able to compress the breast less, it looks smaller on MRI or on mammogram. So this is the classic appearance of a shrunken breast. This is often something that's tested on the boards for the American Board of Radiology. They'll show breasts either on mammogram or MRI that one breast is smaller than the other breast, and that's what's called an invasive lobular carcinoma. Okay, shrunken breast. This is because there's monomorphic cells, which often preserve. Monomorphic cells often preserve the architecture of the duct. So this ILC least commonly presents as a mass and more commonly as a distortion or asymmetry. There's loss of the ECAD here is a common biomarker. And this type of breast cancer is more likely to be multicentric, meaning in more than one of the quadrants in the breast, or to be bilateral. And that's why we talked earlier about we more commonly get an MRI in patients that have invasive lobular carcinoma. So, which mammographic view is ILC most easily visualized? Okay, so good. We're all over the place on this one, which is good. So the correct answer is actually CC. So that invasive lobular carcinoma. Remember, you're not able to see a mass as well. The best compression that we get on a mammogram is actually in the CC view. So when we get that CC view, we're able to spread out the tissue more. So a small invasive lobular carcinoma, we're able to see it better just because we're able to compress the breast out and able to see a small asymmetry or a distortion. We're going to talk about other mammographic views or pathologies. So on the far left of your screen is a small little distortion. That's on a CC view. The second thing that I'm showing here is what's called a tangential view. So if we suspect that calcifications are within the skin, we can essentially roll the breast where we believe that the calcifications are on the skin, and we can take an image under mammogram that shows the calcifications are in the skin. For the LM view was one of the answers. The LM view is what we often get for calcifications that we think may layer. So layering calcifications are calcifications that are within a cyst. This is considered to be a BIRADS 2. So if you think of um, sediment back in the days of your chemistry day, when you put sediment and water, it did a meniscus. That's why we do that LM view. Okay, I'm just going to go through this one quickly. Which time period in the menstrual cycle is background parenchymal enhancement lowest for breast MRI? So we're going to skip this one, and I'm just going to teach it because we're running out of time. So breast MRI in the menstrual cycle. So for us, the best time to get a breast MRI is actually between days 7 and 14, and that the reason why is because at that time of the menstrual cycle, estrogen dominates. And when estrogen dominates, the background parenchymal enhancement is the lowest. So that is the time that we often get a breast MRI. Progesterone is usually when the enhancement increases. So if progesterone is dominating between the days 14 through 28 of the menstrual cycle, that's really where we try not to do breast MRI. We often do not delay doing breast MRI nowadays for patients for its tendon disease. But if patients getting high risk screen, we try to do it to time it between the days 7 and 14. And then perimenopause will be the shortening of the follicular phase. Progesterone is going to dominate. That's usually when we often have a lot of breast pain, patients with breast pain or fibrocystic changes present at that time. And then fibroadenomas degenerate in menopause with no estrogen, and secretory calcifications start to appear. Okay, and this is going to be the last one that we're going to do. So take a look at the lymph nodes. So we're see a lymph node here, a lymph node there. So level 2 axillary lymph nodes are in relation to which structure? Okay, great. So three people answered pectoralis minor, two people answered pectoralis major. So the correct answer is pectoralis minor, and this is one that's commonly missed by a lot of our residents and fellows. The actually lymph nodes are a relation to the pectoralis minor. So this is pec major. This is pec minor. Level one is going to be lateral or inferior to the pec minor. Level two is going to be between the medial and lateral borders, and level three is going to be above or medial to pec minor. There's a node that we call Rotter's node that can be seen between the pec minor and pec major here. That is also considered to be a level two lymph node. Okay, so we're going to skip this one. So descriptor for non-mass enhancement. So this is what's called clustered ring non-mass enhancement. So clustered ring looks like these little holes. Essentially, what you're seeing is the ducts are being seen on FOSS. This is ductal carcinoma in situ that is seen on FOSS. So the ducts are enhancing because you have cancer there. That's something called clustered ring non-mass enhancement. This is a classic appearance for ductal carcinoma in situ. Okay. And in the last case, this is a case that I've seen once in when in my 5 years of being attending. So the finding is what's called a dysplastic cerebellar paraganglioma. So, what syndrome is this finding associated with that makes this patient a high risk for breast cancer? So, this is a dysplastic cerebellar paraganglioma. Once again, right here. The correct answer is Cowden syndrome. This is known as multiple hamartoma syndrome. The lifetime cancer risk is 30 to 50%. It's associated with and I'm not going to pronounce it correctly, Lermet Duclos. And this is one of the many high risk syndromes that are out there. We've spoken about BRCA 1 and 2 earlier. Lee-Fraumeni is a high risk syndrome as well that has multiple different types of malignancies. Peutz-Jeghers is a autosomal dominant polyposis syndrome that patients often present with GI cancers and can have cervical and breast malignancies. And then we'll go over the mutations associated with the various syndromes. So we're going to skip this. Okay, so this Cowden syndrome, once again, this dysplastic cerebellar paraganglioma is the P10 mutation. Lee-Fraumeni is P53. Peutz-Jeghers is STK11. And then we mentioned other mutations associated with an elevated breast cancer risk. So I know I plowed through that last one, but I just wanted to go through the case so at least everyone had an opportunity to see the case. I know we didn't have an opportunity to quiz. So I'd like to open up the floor to questions.
We have one question in the chat. Someone is asking, do you have recommendations for reading material or references, especially for learning breast MRI?
Okay, so that's a great question. So I often think that the best place to start for a lot of things is with the BIRADS Atlas. The BIRADS Atlas is an excellent place to where you can start learning how to speak the language of breast MRI. I think there are some really good resources out there. I think Radiology Assistant does a great job with breast MRI as well. I also think that even though Radiopedia is a very rudimentary type resource, that is also a good resource out there that you can look up the varying different pathologies because they're going to have people that have presented cases. So they'll talk about like for the implant ruptures, they'll talk. There's different pictures of like what the different implant rupture appearances can look like that people have just added on there. So I think those are all good resources that are low cost resources. I would encourage each facility to try to have at least one BIRADS manual on site there. I think that's really important and is something I try to encourage all my residents, but especially those residents that are going to breast imaging to have at least read that atlas in entirety, cover to cover, because I think that really gives you a good solid foundation for both mammogram, ultrasound, and MRI.
Perfect, thank you. And then we have actually a comment from one of our panelist that says, "Thank you for the session. So informative. I enjoyed the teaching style that included case quizzes rather than just teaching alone. This is great."
Okay, that sounds awesome. I'd love to, I'd love to answer any comments. This helps me tailor what everyone would like to learn in the future, whether or not you liked some of the types of cases that we presented, or if you like something else. If you do have the ability to scan here, this is just an evaluation form that you can fill out that would help tailor how I present to the group in the future and what types of cases you would like to present. I just presented a potpourri today just because I wanted to see what types of cases people would like in the future. So if something worked out great, great. If something did not, I'd like to be able to present more in the future.
We
Thank you
have
so
one
much.
more question. Are they able to access the Kahoot uh, after the session, like the questions that you gave?
So the entire session should be recorded. So that should include all the questions that are going through there. So that would be the way that they are able to access it. I do not know if I'm able to share the Kahoot itself. I can see if I can share that Kahoot, but the best way I think is going to be accessing it through the website, the recording through the website, because that will have all the questions that they can look back and forth through the questions.
Perfect.
Thank you so much, Dr. Gilman, for such an amazing lecture. This is definitely one of the best lectures so far.
Thank you so much. I really appreciate it.
Yeah. Thank you so much. I think I do not see any more questions.
Alrighty, thank you so much to everyone for attending and your participation, and to Dr. Gilman for such an informative and helpful presentation. I don't see any other questions in the chat or in the Q&A, so we'll go ahead and conclude if that's okay with everyone.
Yeah.
Thank you so much. Y'all have a great day or a great evening, depending on what part of the world you're in right now.
Thank you so much. Have a nice day, everyone.